Well, hello everyone, and welcome to our case conference webinar via the Academy of Consultation-Liaison Psychiatry. I'm Dr. David Phipps. I'm a CL and addiction psychiatrist at Mayo Clinic, and I'll be moderating this event and introducing our speakers. And just as a reminder, this event is one of many in a monthly series of alternating case conferences and educational webinars, so be on the lookout for the next upcoming event. But today's 30 to 45-minute case conference, representing the pediatric SIG of the Academy of Consultation Liaison Psychiatry, will include a brief case presentation by a trainee, followed by a facilitated case discussion with a CL faculty member, and then end with a Q&A session. So if you have questions, please put them into that Q&A option of Zoom. Feel free to use the chat for comments, but we will only be answering questions from the Q&A option there. So our trainee presenter today is Dr. Keasia Craig. She is a child and adolescent psychiatry fellow at the University of Southern California. And our faculty discussant today is Aishwarya Rajagopalan. And she is an assistant professor of the Department of Psychiatry and Behavioral Sciences at Duke University. And so without further ado, I'm going to hand it off to Dr. Craig for her presentation.
Thank you so much, Dr. Phipps. I am going to share my screen. Good afternoon, everyone. Thank you for joining us. Today's case is titled Overvalued or Delusional, Navigating Capacity and Treatment Refusal in an Adolescent with Restrictive Eating and Malnutrition. Our patient is a 16-year-old male with no prior psychiatric or medical history who presented to the emergency department with roughly 30 pounds of weight loss over 3 months. He had progressive food restriction that evolved over several months into an exclusive raw meat and raw dairy diet with no cooked foods at all. He attributed this to acne, fitness, and weight goals significantly influenced by a YouTube raw food creator and a peer. His mother became concerned about his eating habits and weight loss and brought him to the ED after he said he didn't want to be alive if admitted and forced to eat vegetables. Key background history includes an autism evaluation and diagnosis at age 3, which was later rescinded. Patient also had a history of a speech delay and special education classes through 4th grade. In 4th grade, he described experienced bullying, which triggered his first depressive symptoms and passive suicidal ideation. He did not have any prior suicide attempts or hospitalizations and no psychiatric diagnosis. For family history, there was a distant family history of schizophrenia. He lived with his parents and brother in a Spanish-speaking household. In the emergency department, his vitals showed bradycardia with a heart rate nadir of 45. His BMI was 19.1 in the 23rd percentile. And in pediatrics, BMI for age percentile is key. He was in the 23rd percentile with a 20% weight loss, which indicated severe malnutrition despite a seemingly normal BMI. His lab work showed an elevated BUN and creatinine ratio due to a mild acute kidney injury. His CBC and urinalysis were unremarkable. His EKG showed sinus bradycardia with a QTc of 396, and his Campylobacter PCR was positive, which resulted later in his admission. On mental status examination, he was calm, cooperative, and linear. There wasn't evidence of any thought disorder or no perceptual disturbances. For thought content, he was perseverative on dietary practices. He denied active suicidal ideation and felt safe. His insight was poor and his judgment was fair. Overall, patient had intact reasoning but problematic belief content, and this was the tension in the whole case. So ultimately, he was admitted to pediatrics for medical stabilization with a multidisciplinary approach, including hospital medicine, adolescent medicine, and psychiatry. He had an initial diagnosis of avoidant and restrictive food intake disorder, which was later revised. The eating disorder medical admission protocol was initiated at a goal of 3,200 calories with slow caloric advancement to avoid refeeding syndrome. Thiamine and vitamins were started, and psychiatry followed throughout, and as the team got to know him, our concern grew around the rigidity of his beliefs. So the patient's beliefs were internally consistent and deeply held. He believed cooking destroyed nutrients, raw food is cleaner and more bioavailable, and that his diet was a conscious and researched choice. Some key statements include when told a YouTuber who was eating raw meat died, he said, quote, they died from falling off a bridge, not from eating raw meat. When his Campylobacter came back positive, he attributed it to a lab error. He worried about artificial dyes and citric acid in the hospital foods and told us, quote, I don't want my parents to be indoctrinated with the information here. So this is the clinical picture that sets up our central question. So overvalued idea or delusion? We had genuine evidence on both sides. For overvalued idea, in this case, the belief had a traceable origin in peer influence, online content, and body image concerns rooted in his bullying history. It was egocentric, internally consistent, and showed partial flexibility. He was willing to quick sear lower quality meats at home to reduce infection risk. Some complicating factors, he attributed the positive Campylobacter result to lab error. He rationalized the YouTuber's death and developed escalating paranoia about hospital food and medications, including refusing meds because of additives. And critically, malnutrition itself can impair the very cognitive faculties we were using to assess insight. Our primary diagnosis was anorexia nervosa with overvalued ideas, given the history of restriction, body image concerns, the egocentric distortions, rather than a separate psychotic process. Orthorexia was also on the differential, given the purity fixation. And then delusional disorder and brief psychotic disorder were also seriously considered, given the paranoia about chemicals, rejection of lab results, and no prior psychiatric history. Initially, we gave the diagnosis of avoidant and restrictive food intake disorder, but this was rescinded given the history of body image concerns. So our formal diagnosis was anorexia nervosa with overvalued ideas. Psychiatry recommended olanzapine 2.5 milligrams given rigid thinking and paranoia. Mom consented, however, the patient refused and continued to refuse throughout his admission, citing additives in the inactive ingredients. He could articulate the risk, but rationalized everything through his belief system. His reasoning was intact, but his insight was poor. The team determined that he did have the capacity to refuse medications. He was eating sufficiently, so he wasn't gravely disabled, and then there was no suicidal ideation or self-harm, so he didn't meet criteria for an involuntary hold. Treatment could not be forced, and this is the decision that we wanted to unpack a little bit more with this case. So these are some questions to consider for discussion. How do we distinguish an overvalued idea from a delusion when malnutrition is clouding the picture? When reasoning is intact, but the belief system drives harmful refusal, how do we document capacity? How do we manage the ethics of antipsychotic initiation when a parent consents and the adolescent refuses? And how does online health misinformation shape our diagnostic and therapeutic approach? And with that, I will turn it over to our expert discussant, Dr. Rajagopalan, with our questions and discussion.
Thank you so much to Dr. Craig for this excellent case presentation and to the Pediatric SIG and to ACLP for putting forth this opportunity for discussion. There are so many pieces we can dissect, but in our limited time, I'm going to try to focus on a couple of the questions that Dr. Craig has highlighted for us. First, I want to set the stage by saying we do not assume that all minor patients are unable to make decisions on a global basis, particularly as children transition through adolescence and approach adulthood. It may be developmentally appropriate for them to take on more participation in their healthcare. So this is where a really nuanced assessment of developmental stage outside of that chronological age you see in EPIC really matters, because there may be some 16 or 17-year-old patients who can readily engage in robust discussions around their healthcare choices. And depending on where you live, the state legislature and their guardians may support that type of engagement. But there may be other older adolescents who cannot meaningfully engage in these types of discussions, and decisional capacity really rests with their guardians. So my sort of first pearl is to say, be familiar with what the local and institutional policies are, and make sure you are familiar with sort of getting a good sense of that developmental age and stage. Secondly, I want to say that malnutrition itself can be challenging to diagnose. In minor patients, we are really fortunate that they are developmentally expected to grow, so using growth charts is a really fruitful tool for us. Growth charts allow us to plot those expected trajectories of height and weight and can demonstrate concerning trends even before vital signs like blood pressure and heart rate or lab findings can yield acute concern. So when we hear that there's a concern for malnutrition, the task becomes discerning alternative explanations ranging from malabsorption to infection, like you mentioned in this patient, and how those could be contributing to the presentation. As a CL psychiatrist, no matter the age of your patients, we're often invited to the proverbial table to help broaden that differential. So what can help us in doing that is a careful understanding of the patient's thought process. And that's often where the central question emerges. How do we decide what is an overvalued belief and what is delusion where such a concern exists? So when we're calling something overvalued, and certainly this applies for me, that suggests that there's an ascribed value in the social context. So to that end, when I'm appraising a belief, it's with the understanding of what the dominant social culture recognizes as a reasonable belief and having a broad spectrum of understanding. And then I also need to know what is known scientifically about that belief, knowing that these two things can be at odds, and also that what we know scientifically can change over the course of time, just like the dominant social narrative can too. Understanding that social context is important because the framework that we use, location by location and cultural upbringing by upbringing, are heterogeneous. So this is where collateral from individuals who know the patient well and those who have similar experiences can be really useful. In many cases, this can be parents or other family, but outpatient clinicians can also be really valuable partners in understanding, is this a new sort of thought process or is this something that has been present durably across the lifespan? And being able to systematically understand what beliefs came from within that family system or what may be specific to the patient themselves, what may be related to their culture, or what may be related to the sort of more dominant culture can also help us to avoid overvaluing dominant cultural lenses where they're not appropriate. And that's certainly a bias that I have caught myself being entrenched in my own clinical work. So this patient shared beliefs that may have started and perhaps started out with that orthorexia lens, an interest in obtaining health and following sort of YouTube-based creator. But it clearly crossed into what was appropriate and safe for them. And so I would also emphasize that though that autism diagnosis was rescinded, concern for neurodevelopmental differences may also contribute to that establishment of their value system and the flexibility of their own thought process. And so that's important to understand and recognize in our sort of conceptualization. Unfortunately, we know this patient began to lose weight and further restrict their food, predominantly to raw meat and raw dairy. And trying to sort of work through what of that is overvalued belief and delusional belief is the capacity for engagement in alternative viewpoint. Overvalued beliefs, allow for some negotiation in other viewpoints, allow for entertaining alternatives, even if we don't totally align with them. So an example of this is being able to have a spirited debate, even if I'm not going to change my opinion. But it sounds like this patient remained unable to tolerate viewpoints that did not support that diet, despite robustly provided evidence and opportunity for discussion. I'm going to sort of shift gears towards malnutrition and decision making. We know that even before we see signs and symptoms of malnutrition on labs and vitals, we can see neuropsychiatric changes, like changes in mood, cognition, often brain fog, that can suggest that nutritional impact. So I'm often going to say when I'm asked by trainees and colleagues, like, do we think someone's nutritional status is impacting their cognition? The answer is yes. We all know this ourselves when we're running around on busy service lines and don't get to stop for lunch that day, right? But it also speaks to why capacity is a dynamic entity. We can restore one's nutritional status, and therefore we can expect to improve cognition by doing so. And so in pediatric patients who have not been ill for a prolonged period of time, we can actually see this happen fairly robustly and rapidly. Clinical suspicion can help guide this, but objective findings can also be useful using that growth chart, looking at your labs and vitals if they're there, and physical exam findings for malnutrition, looking at brittle nails and hair can also be really useful. And to your point about reasoning being intact, this is where your collateral is also really useful. For me, that collateral piece allows me to consider whether the reasoning is in line with their pre-morbid baseline or if it's really shifted in the time of restricting. Because the tenets of capacity include that rational manipulation of provided information to make a choice that is in line with the patient's values. And so understanding what those values are before they became ill is so important. And so that really helps to inform whether that information is actually being rationally manipulated or whether the manipulation is occurring in the context of this closely held belief that is bordering on perhaps delusional content. This is very nuanced and challenging, particularly for adolescents, because they may not have had robust opportunities to express thoughts and feelings about healthcare decisions. They may not have had preceding illness episodes. And it also is really challenging for our general psychiatry colleagues, for folks with severe and enduring feeding and eating disorders who may have been ill from childhood or for such a prolonged period of time that even collateral may not be able to recall times when those disordered cognitions weren't driving the ship. So one important consideration for adolescents is that they are also allowed to make decisions that we don't align with when they're assessed as meeting criteria for decisional capacity. It is really hard as an adult, particularly for me, to sit with that when I'm thinking about the gravity of some of these decisions. And so we are assessing that against the implications of the decision at hand in the same way we do with adults. And in a situation like this, I would note that the decision to decline a psychotropic medication may be of less consequence than to decline the nutrition they're being presented with, given we know that the treatment for malnutrition in the context of restrictive eating is primarily restoring nutrition. But it's a challenging dance to do because sometimes the medication is what facilitates increased engagement in that nutritional plan and helps address some of the disordered cognitions or anxiolysis. So making that balance between autonomy and beneficence allows us to still be good stewards of patient decision making where it aligns with their values and their safety remains preserved. When it's assessed that the patient's at imminent risk, which was not the case here, then I would consider it similar to any other severe psychiatric condition, right? So we're talking about status post a suicide attempt or in a refractory psychotic illness, where we as a treating community would largely understand the role of treatment over objection. But this is going to be very variable location by location. And after all that has been said, I also just want to highlight one important point, which is that the dominant social culture itself is immensely problematic. We live in a society that is fat phobic and has created a cultural narrative around weight and shape that's prioritized BMI and body fat percentages over objective markers of illness. And so even among us as psychiatrists, we have our own biases. This is amplified in a social media and digital culture, right, that allows rapid access to unfiltered and unfettered inaccurate information with varied degrees of secondary gain. So youth are developing the skills to appraise information and use sources, but they're still vulnerable to exploitation in these environments by influencers and influencer culture, particularly folks who are monetizing these opportunities. So in a critical period of development, youth can be engaging with harmful content that can lead to those overvalued beliefs that can become a disordered eating cognition and an eating disorder in due course. I also just want to highlight that people have lived experiences different than our own. And so those cultural backgrounds may have values and beliefs that can influence the healthcare itself and contribute to trust and mistrust of the healthcare system. So really wanting to call out how structural racism, sexism, ableism, and classism among many entities can shape the way that our patients engage with us. And I find myself having to consistently check what elements of my own bias are coming to the table and presenting in my assessment. But I'm going to take the last couple of minutes to just quickly walk you through how I, as a child and adolescent psychiatrist, would approach this capacity evaluation. So first step would be about communicating a choice. I'm going to ask this patient and their collateral sources, what is the communicated choice? And I'm going to review the record to see whether this truly has been a consistently communicated choice. When I'm looking at understanding the relevant information, I love when the primary team can provide me what materials they've given the patient for review. If there's anything printed out, I want to read it. And I'm also asking the patients, what TikToks are you looking at? What blog posts are you reading? Show me them. I want to look at them too. This is how I build curiosity, particularly when we have a high degree of suspicion for misinformation or disinformation. And partnering with patients to non-judgmentally review some of this content can be an informative way for me to gain insight and also appreciate kind of what the next steps will be. So then when we're thinking about appreciating the situation and its consequences, gosh, this is hard for teenagers who have invincibility complexes. So I often ask what they've heard and read about consequences and what does it mean for them? because teenagers often overappraise their capacity for resilience and recovery. And so we integrate that into the rational manipulation of information. And important to this is also our own understanding of the situation and knowing what the sort of weight of the different decisions are. So the bar to observe diminished capacity is going to be substantively different in a life-altering decision like declining nutrition for someone who meets hospitalization criteria versus declining a psychotropic medication, which may be very helpful but is less essential in that moment to the treatment. And then last but not least is going to be that rational manipulation of information. So now that you know what the information is that the patient has and what all the sources are, communicating to that patient and their guardians, right? What am I seeing? What am I hearing? And how does that formulate into my understanding of their decisional capacity based on the pre-morbid values that we were presented with? And this is the opportunity I take to discuss the discrepancy between the information that they've been presented with from the primary team or from other sources, and then kind of what I'm seeing. But I'm not going to overemphasize the piece about misinformation or disinformation, because in the moment of an acute crisis, I've often found it futile. Particularly when a capacity question is being addressed, because that already can be a tense or terse interaction. So that may not be the best moment to say, hey, that YouTube creator that you're looking at, like they're kind of a charlatan. Not the best time for that conversation. I also want to say there's no specific interval for reassessing capacity for any particular decision. But malnutrition encephalopathy, is an evolving sort of construct. And so in our institution, patients on our feeding and eating disorder protocol are seen daily. So I am in the business of documenting daily adjustments to my capacity assessment with new information that I'm learning or gleaning from the patient. And as I said earlier, kids tend to reconstitute fairly robustly with nutrition, which is awesome. And so that may not be a terribly long addition to the note. Lastly, I'll kind of touch on this misinformation piece. I already mentioned, I think it's important to know where and how patients found sources. I also have often found that it comes from a place of feeling invalidated or ignored in various elements of the healthcare system, why there's sometimes that tense interaction. And so I find it fruitful to challenge primarily the beliefs that jeopardize safety insofar as it immediately impacts the treatment plan. So if the conversation is about declining nutrition, I will emphasize, right, like we're seeing signs of refeeding syndrome, which can be fatal. And I try to be compassionate but firm. But really essential to try and meet the patients at a point of mutual agreement. So for teenagers, this may be a desire to return to their life. Maybe there's a graduation or they're hoping to get to college in the fall. And so if we can unite around that shared goal and we can scaffold what the steps are, we may not agree about what we need to do to get there, but we can at least partner to try day by day. So in this particular case, I might defer the conversations about cooked food being harmful or about the additives, and I would treat it similarly to, firmly held beliefs in psychosis or in other conditions that I would expect to improve with the treatment of malnutrition. I don't know that I would be able to make any substantive ground in addressing it at the outset of treatment, but I can imagine that I would be potentially damaging therapeutic rapport if I was trying to challenge that right at the beginning. And so I think that's why a lot of our restrictive eating protocols include an option for treatment over objection where there's really that life-threatening malnutrition and need for someone to receive that nutrition emergently. But for sort of these less emergent aspects of that thought process, approaching with a balance of curiosity and understanding, which you did, and encouraging people to learn about their health in safe and developmentally appropriate ways while emphasizing those therapeutic boundaries for the treatment frame. And then I sort of just wanted to touch, because you also asked about the documentation piece of capacity. I do have a smart phrase in EPIC for this purpose that my Duke colleagues in the chat will recognize well. But if I can just summarize my remarks generally, what I want to say is that performing these evaluations across the lifespan is tremendously difficult. I think being able to contextualize what we're hearing from the patient and from their caregivers with what information's been provided by the healthcare team while really carefully incorporating and also questioning that dominant social narrative using a culturally tailored lens can inform where someone's cognition is not only relative to their baseline, but also to appreciating what a range of reasonable choices really is. And when we're weighing autonomy and beneficence for minor patients with emerging decisional capacity, remembering that our own bias can also influence clinical impressions is vital. Lastly, as CL psychiatrists, we're lifelong learners, so we're going to continue to evolve as our consult questions do. I'll turn it back over to Dr. Craig.
Thank you so much, Dr. Rajagopalan. I'm going to share my screen again. So to close, over the 25-day admission, his weight increased from 53.8 to 59.7 kilograms, a gain of 5.9 kilograms with no evidence of refeeding syndrome. He did eat sufficiently throughout admission, but told us directly he's eating to get out and planned to resume his raw food diet at home. He did not meet criteria for an involuntary hold. He was transferred to an outside hospital inpatient eating disorder program for continued stabilization. Olanzapine was prescribed at discharge, although it was never taken. He had outpatient therapy that was in place, and he had a celiac panel, which was pending on discharge. Thank you all so much for listening today, and I'm going to hand it over to Dr. Phipps for the Q&A.
Excellent. Thank you very much. We already got a few questions in the line here. And one I think would be very helpful for our adult psychiatry predominant audience is, we spent a lot of time talking about the capacity assessments and how that fluctuates and how things change. And curious of how that is adjusted in the child population when technically the person who is consenting to treatment is theoretically the parents. How does that intertwine with the capacity of the child versus if the child doesn't want to do something but the parents override that? Can you touch a little bit on that?
Yeah, that's a great question. And I think first and foremost will vary state by state because in different states, the age of consent will be variable in terms of consenting to psychiatric treatment. So sort of the way that I would think about that is that while the parents can provide all consent, I think that works out better on paper than it does in real life, in terms of discerning when to integrate a treatment over objection framework. And so the developmental stage of the child in this case, they're, a late teen, being able to assess what their understanding of their own body and nutrition is sort of the foundation of that. And then, really understanding that in the healthcare system, there also may be institution by institution policies that govern. So it may not be acceptable in one's own institution then to provide psychotropic against a child's objection, if they're of a certain age or certain stage. And so while the parent and guardian may consent to the psychotropic, right, ultimately the kid's got to take it. And then we as the CL psychiatrist have to help the team sit with, is it worth escalating to forced medication, potential use of restraint to be able to deliver the intervention versus are we going to partner with the child and recognize that they are participating in the treatment plan that is the most essential component, even if they're not yet willing to participate in the other elements.
That's a good point,
Yeah.
especially because the capacity assessment opens the door for a discussion of their desires and allows you to maybe use some motivational interviewing to bring them to behavioral change as well, certainly.
Yes.
Another quick point that we had in here as well is you talked a good bit about how there may be limitations in how we address this health misinformation, especially more in the acute setting when someone gets really defensive. But there is an importance in addressing that to some degree. Can you discuss maybe a little bit more process of addressing that, because that's a very common component and is becoming more and more common with our CL consults, certainly.
Yeah, gosh, I feel like every time I'm on service, there's some component of, having received information through a source that I perhaps may have chosen differently, right? And so wondering about how do we have those conversations, I think first inviting patients and families to bring forth what materials they have. With that curious lens, like I'm curious about where you heard that, or I'm wondering if you can show me what you've been seeing or what you've been reading, and if I can have an opportunity to review it. So I will be happy to watch TikToks or Instagram Reels or what have you to try and understand the content. Because if I'm sitting from that position of, well, what I read in the literature is X, but I haven't actually engaged with that material, I think it doesn't land very well and it seems disingenuous. But if the patient can see me sitting there watching the content and then, sort of stratifying, What is of the highest acuity to respond to in the moment? So am I going to choose that moment to engage with something that's minutiae relative to the big picture versus sort of the biggest picture item is like, is this person going to take nutrition in the hospital? And so then talking about like, I hear you about your concerns, and I understand that I may not be able to convince you today that the hospital food is safe, but it is what your bodies need, and it's what we're going to be providing today. And I say that as compassionately and firmly as I can. And then day by day, as we build some trust, as we sort of build some understanding, engaging piece by piece.
Excellent. Well, I appreciate everyone coming to our webinar, and just for timing purposes, we're going to stop there. I appreciate you both with your excellent discussion and case presentation. I appreciate our audience members with good questions as well. And I appreciate everyone joining us. If you missed it or wanted to share it, they will post this webinar on the ACLP website and on the many different social media platforms of ACLP as well. But I thank you again for coming, and we will see you again next time.